Hello, everyone. My name is Matt Moreau, and this is my applied research project proposal for my Doctor of Athletic Training degree at A.T. Still University. My ARP project is an original research project and is titled Descriptive Report of Injuries Sustained by Secondary School Baseball Players Categorized by Level of Community Socioeconomic Status. I have no conflicts of interest in relation to this research. Baseball is America's pastime and is one of the most popular sports amongst youth athletes in the United States. It's the third most sponsored sports amongst U.S. high schools, and it's the fourth most popular sport by participation amongst all male sports in the U.S. Injury rates of high school baseball athletes have been found to be between 0.98 and 4.0 injuries per 1,000 athlete exposures in the past 25 years. Specifically, previous studies have helped to highlight the predominance of non-time loss injuries in the sport. However, other factors such as socioeconomic status, or SES, have not been studied in relation to injury rates. Healthcare disparities have been on the forefront of national media attention in the past decade. Specifically, attention toward community-level factors such as socioeconomic status have gained the spotlight. Social inequalities in healthcare appear to be prevalent. However, data related to athletic healthcare in these communities is limited. Previous research examining socioeconomic status and athletic healthcare has typically focused on AT services provided. Unfortunately, these studies have described SCS in a very limited capacity. Baseball is a sport that draws from all populations on the SCS spectrum. However, young students from lower socioeconomic status communities typically don't participate in as many team sports. Understanding injury characteristics across the community SCS spectrum may help inform healthcare and resource needs in these communities. Therefore, the purpose of this study was to describe the characteristics of injury sustained by secondary school baseball players across levels of community SCS. This study is a descriptive epidemiological analysis of injuries, exposures, and treatments of high school baseball athletes. Data was obtained from the Dataless Center's National Athletic Treatment, Injury, and Outcomes Network Surveillance Program, or the NATION-SP. The data came from 48 secondary schools across the United States who provide AT services to their student athletes in some capacity. These high schools may provide AT services in the form of full-time employees of the high school themselves. They may contract these AT services out to hospitals or physical therapy clinics, and they may just be part-time or per diem. It varies depending on the school. The data was collected from the 2014-15 through 2018-19 academic years and included time loss and non-time loss injuries, exposures, and treatments. The de-identifiable data was submitted online by ATs at each school and was then checked for quality control by Dataless staff. ATs were contacted within 24 hours if any discrepancies were noted in the data and were asked to make any changes if something didn't add up. Socioeconomic status was determined by the zip code tabulation area of the school. Variables to determine socioeconomic status included African American population of the community, female head of household statistics, number of households on food stamps, public health care coverage, number of children under the age of 18 in the community, households without employment, number of people on public assistance, income and poverty levels, median household income in the community, and educational attainment of the population. These variables represent the most robust analysis of SCS currently in the literature. Schools were then placed into three categories of community disadvantage: disadvantaged communities, average communities, and affluent communities. We used common definitions previously used in the literature. Injuries were defined as conditions treated by an AT, physician, or both, and occurred in a team activity. If injuries which did not occur in a team function were not included in the data. Diagnoses were grouped into the most common categories such as sprain, strain, fracture, etc., while body parts were grouped into primary regions such as the knee, head, and shoulder. Mechanism of injury were split into 3 general categories, including contact, non-contact, and overuse. We chose the amount of time loss experienced as our measure of outcome, as is commonly used in similar epidemiological studies. Results showed an overall injury rate of 2.4 injuries per 1,000 athlete exposures, with 2.3 reported in affluent communities, 1.4 in average communities, and 3.3 per 1,000 AEs in disadvantaged communities. Injury rates in competitions and practices followed similar patterns between the communities, with disadvantaged communities experiencing higher injury rates in both competitions and practices when compared to affluent and average communities. We found that the highest rates of injury occurred in disadvantaged communities, while the lowest rates of injury occurred at schools from average socioeconomic status communities. Overall, injury characteristics were pretty similar across all SES communities. However, schools from disadvantaged communities did see a higher percentage of overuse injuries. Another interesting finding was that the schools from disadvantaged communities appeared to have a lower percentage of severe injuries as they relate to time loss than average or affluent communities did. As noted earlier, injury rates in this study were higher than previous studies examining data from the nation. This may be due to the type of AT services provided, as only 50% of schools who offer athletic training services employ them full-time. Additionally, the importance of documentation amongst the AT community has risen in the past 25 years and may also result in an increase in injuries being reported to injury surveillance programs. Another interesting finding is that schools in disadvantaged communities experienced higher injury rates than those in affluent or average communities. This is a concerning finding, considering schools in lower SES communities are more likely to not have AT services at their schools. Future studies examining injury trends and access to healthcare across the SES spectrum should use similar robust metrics to maintain consistency in the literature. One limitation of this study is that we were only able to capture data from schools which provide athletic training services. We're unable to determine if injury rates differ in schools without ATs, or if schools in communities with higher SES are more likely to provide access to ATs. As a result, this study may not represent the true impact on lower SES communities. So, in conclusion, high school baseball injury rates differ by community SES, with disadvantaged communities seeing the highest injury rates. Many similarities exist, however, between injury characteristics and time loss outcomes regardless of SES. This suggests that injuries may not be more severe, even though they may occur more frequently in disadvantaged communities. This, to me, expresses the need to know what AT coverage looks like in these communities, and how this may affect the healthcare access to schools in these communities. Finally, injury rates and characteristics of community SES provides insight into athletic healthcare needs of different communities. References are provided here. And I'd like to close by thanking Dr. Valier, who was great in guiding me through this process, and also to the rest of the ATSU faculty and students who helped make this a fulfilling journey. Thank you for your time.